It's called the Smile Conference for a reason, because I think after that performance, we're definitely all smiling.
Yeah.
So
I was hoping you would do this in opera, actually. Every question you should sing in opera, right? And then
yeah, no, with my questions, we may have to lose yourself in the music, the moment. All right, let me get started. So first question I have is for CT, and then I have a question for Nigam after that. So there is, this idea that alert fatigue is often reported qualitatively. I've seen it over and over again, where you turn something on and you get the call, like we're getting too much alert. And I think you shared kind of quantitatively that you're getting 61 alerts per day, among 1 to 2 like true deteriorations. So did you guys ever try to formally like assess or measure, or do you have any ideas around how do we formally assess alert fatigue? Not just number of alerts, but actual like fatigue.
Wow. It's something we're all grappling with, right? One other parallel project I'm working on right now is our electronic health record in-basket messaging project. And we know for a fact that our patient portal messages have tripled since the onset of the pandemic. We used to receive 54,000 messages a month. We're at 184,000 incoming each month. And how do you deal with that? Well, you can say these are the numbers. But then the question is, alert fatigue, is it false positives? It's what the benefit of having a virtual health center team is that's all they're doing 24/7. And we can ask them, we know the incoming volume. How many phone calls did you actually make for where it met your level of clinical suspicion? And this is what we're getting from that. So there's a very much a human intervention piece of it. And then you're right, the rest of it ends up being very qualitative. I hate all of you, CT Lin, on your team because you're sending me thousands of these. I don't find any of these helpful. And it ends up being sort of an ethnographic deep dive. But yes, it's a mixture of numbers and it's a mixture of qualitative response. I don't have a great systematic method of doing it.
Thanks. I just want to, that's a great reply, really helpful. And I just want to point out that in chat, Mark Sendak from Duke shared a publication around cancel alerts. And I think for some kinds of alerts, you can look at that. For other ones, there isn't a feedback mechanism. So that's, thanks, Mark, for pointing that out. Nigam, any thoughts around that? The idea of trying to quantify alert fatigue, how much is too much? Because depending on the clinical scenario and situation, different numbers of alerts being generated might be acceptable.
So I've come to a very consequentialist view of things. That number of alerts is too much, at which they stop paying attention. And that will vary by the team size, the workload they have, the setup of the, and the nature of the other cases in the ICU and so on. So I think it's very hard to come up with an objective answer that says, 2 per 20 minutes is too much. But it will have to be something of the nature that at some point you've saturated the person's attention span, so stop bothering them.
And I'll also add that we are not anywhere close to consensus because all it takes is our C-suite and our executive directors, and in fact, with the pandemic, our infectious disease doctors speak with much louder voices than they ever have in the organization. And they will tell us, and actually this was before the pandemic, we can't even have one Ebola case come through. Well, that means 100% of ambulatory and ED visits, you start with, what's your travel history? Have you been overseas? And you know what? The hit rate is 0.000000001, or maybe it's 0 all the way across the board, and yet it's not satisfactory to turn that off because the value to the organization is so high for this one question.
So Nigam, your point around the fact of being consequentialist, I think it's also worth taking into consideration that physicians will work until they physically can't work anymore. Nurses will work until they physically can't work anymore. So just like the kind of when you're tuning like a lasso regression model and you have the option to choose the best fit or the one standard error away fit, we may want to think about the capacity as a one standard error away is kind of where we want to stop.
Right. I don't mean consequences as in they stopped paying attention because they passed out.
So Nigam, you talked a little bit about, resource constraints and net benefit, and using that as a way, as part of kind of delivery science. Now, interestingly, if one organization has resource constraints that don't exist at another hospital, and you simply try to kind of maximize net benefit, you're going to end up not implementing the model at places that are more constrained and implementing it at places that are not constrained, potentially worsening kind of this digital divide, or propagating this like difference between different types of hospitals. Is this a fixable problem, at some kind of local or societal level? This issue around actually trying to deploy, and deployments mostly happening in well-resourced places.
Well, I mean, if the work that you're leading succeeds, then hopefully we'll have a framework to share on the evaluation side, to say your model can only be useful in such resource settings. I understand it's preliminary, but I think that's the kind of stuff we need setting up in our evaluation, saying this will work if you have 5 nurses and this much staffing, or this will not work at a resource at a level where you have 1 doctor overseeing both the general ward and the ICU bed.
Yeah, in CT, I think you touched on this a little bit as well. One way I think you dealt with it at UC Health was you set up a virtual team that essentially, so even if the local hospital doesn't have the resource or time available, you had kind of a virtual team kind of acting on this. Who funds that kind of a virtual team? That reminds me a lot of like remote tele. Remote tele is something that obviously a hospital funds to have some people watching telemetry when you're, for a different floor. This is almost like virtual tele at the hospital level. So how did you guys come up with that? Where is that funding at UC Health coming from to make that kind of a team possible?
Yes, excellent question. So I think this was fortunately an initiative led from the top levels, our organization believing that our performance was not satisfactory and that we would scrape from our clinical resource bed and say, we're going to reallocate these nurses to constant monitoring. We also do actually have a fair number of nurses with physical injuries, back injury. They're cognitively great, and yet they can't do the lifting bedside work anymore. And can we redeploy them? And that was sort of a perfect match in that situation. We've since seen so much value from it that we're going to continue to expand the program. And yes, one of the early values of this was having a critical care doc and a nurse serve the critical access hospitals that could not set up their own infrastructure. And we're in sort of conversations with non-UC Health organizations that want to subscribe to us as a service, that these folks could extend their work onto non-network hospitals. That's harder to do, but it's, instead of software as a service, it's, VHC as a service kind of thing.
Yeah, and so there's a great question that came in from Yvonne Liu, which was, anytime we're doing a AI-driven operational change in your workflow, the question comes up when you see a benefit, how much of it is stemming from the AI? How much of it is stemming from the actual operational changes? It's really hard to decouple that. In your trials, when you went from trial 1 to trial 2, do you have any ideas around how you, either decoupled it or said, we don't need to decouple it, let's look at it as a package deal?
I can very briefly say that when we showed things to the bedside nurse and physician, we had 0 change in behavior. So we measured time to antibiotics, time to fluids, and actually to the minute, no change with trial 1. And so all of it was with trial 2. So in that case, yes, but you're right. There are many other implementations now we do that go straight to the BHC, and it's both the BHC and the algorithm. And what part is the algorithm? Yeah, good luck trying to take that apart at this point.
Nigam, any thoughts on that? Decoupling, as part of delivery science, the algorithms, like if something works, how much of that was the algorithm, how much the intervention? Similarly, if something doesn't work, how much of that was the algorithm's fault versus the intervention's fault?
So I have 2 thoughts on this. One is the sort of the technical thought of, how do you correctly assign attribution, right? And then the other is the social side of it. I mean, success has many fathers. So I would assign attribution to multiple sources and create the team culture as opposed to try to attribute it all to the AI. And I mean, we definitely want an honest estimate that the attribution to the algorithm is not 0 or negative. That by taking it out, we might increase productivity. If that is the case, we should definitely take it out. But if it's greater than 0, then I wouldn't sort of make it too big of a deal to claim attribution just for the algorithm.
Yeah, and Mark actually asked as a follow-up, what's the need to decouple? I guess my thinking on this, asking this question was that there are times where you're thinking, do I need to swap out the model? And there's times you're thinking, do I need to swap out my intervention? So trying to figure out which one to swap out, if you find that you did a little bit better, that might be the kind of the value there. So next question I have is, this one comes from Carl Dirks. And I think this was CT to you, but with the virtual healthcare team, are they seeing, things like unverified vitals that are coming straight off the monitor? And how do you deal with kind of whether it's medical legal or, just safety wise, that, if the signal is wrong and they have the authority to prescribe that they could make a medical error, how did you guys think through that?
We have an excess of caution at our organization. So when you actually go and sit with the bedside, sorry, with the VHC nurses and they say, here's an alert, they spend 10 to 15 minutes per chart when they look at the alert. So, oh, there's an alert, let me go look. What's this patient here for? What's their post-operative day? Clinically, they apply their nurse brain to, does this alert make sense in the context of the rest of this patient's chart? And only after they've spent that 10, 15 minutes do they go, I think this is real. I'm going to start calling for the next step in this. And it's not straight to antibiotics. It's sepsis. It's lactate CBC. And only with the additional confirmation of that lab in an hour, lactate's high. You know what? That's enough. We're going to pull this trigger. So we're pretty confident that that process is not based on, oh, this number jumped, therefore we're prescribing. There's a lot more to do with that, which is, of course, the same critique of, yeah, you put AI, you're just dressing up nurse intervention with this sprinkling of ML that's really not doing much for you. But yes, right now it's very heavily nurse driven, and we're very far from the idea that an ML will come in and just swoop in and take over and make errors. There's nothing like that, and we're not even close to it.
Thanks. That's a great question. It's a great response. Nigam, one thing you had on your slide was, you had a slide on teaching models to be fair. And I guess the question I had in response to that was, because I think you were starting to elaborate, but maybe you can elaborate more, is can we really teach models to be fair when the underlying data comes from kind of an already unfair allocation of resources? And can you speak a little bit more about that?
Sure. So no, my main point is we currently try to teach the model to be fair. And I think we should definitely try to do that. But I think the bigger issue is to ensure that the action taken in response is equitable. And I think the model side is probably 10, 20% of the story. And then how we think about the action is probably the larger share of the net consequence or impact. And so, in fact, one of the things that we've been saying is that there's a risk in having these algorithmic approaches to fairness that we might just end up fair washing. And this is, Zach Lipton's term, and hide behind sort of misguided math to say, all right, we're giving the same number for, Nigam and Karandeep, so we're good. Like that might not be true. So I'm suggesting the opposite, saying we should look at the larger frame of what are the differences in the accrued benefit to someone and how much of that are arising from your intervention policy and the actions you're taking.
CT, any thoughts on model fairness? I know you didn't touch on it on your talk, but it comes up at the highest levels of at the operational level, trying to ensure that whatever we're doing when we do these kinds of approaches is fair. I guess, how has that come up at your organization, or has it come up?
Yeah, so I'm already worried that our model as it stands is not good enough. in our partnership with our teams, even though trial 2 is VHC, you notice it doesn't say trial final. We're not anywhere close to, I think, configuring the exactly right way to do this work. And then to layer on top, diversity, equity, inclusion. Hey, CT, are you measuring, what the impact is? I'm like, oh, that just scares the pants off of me. It's hard already at 2 or 3 levels, and we're going to add another layer of complexity upon it. We're not anywhere close to being ready to say, yes, let's grab that one and run with it. We do now have a vice chair of diversity, equity, inclusion, and we are having her join our meetings, and we're sitting there scratching our heads. What is the right approach? We add another 2 people whose job it is to look through all of the race data, our ethnicity data, and make sure that we're not disproportionately alarming here versus there. And by the way, the first thing we're going to run up against is it doesn't exist in the EHR. People skip that field all the time. And so where do you start, right? To the point about, is this a good ML model? Is diversity, equity, inclusion a good? No, we have no data. Yeah. And sometimes, unfortunately, it's the front desk person looking at the person across from them going, yeah, I'm pretty sure this person is that's not very good. So this is a huge hill we have to climb, and we're not even ready for it. So yes, excellent critique. And I feel that right here.
Yeah, and the thing I'll sort of jump in with is that in the United States, race is a social construct. What we're really after in medicine is to try to answer the question, where is somebody from? Because knowing that tells you the exposures they've had and the genetic inheritance that they've carried with them. That does have value. Like knowing somebody's from Southeast Asia alerts you to G6PD deficiencies. Knowing they're from Africa alerts you to potential sickle cell disease. But here, race has a very different meaning. And like when I came into this country as an immigrant, like the first couple of months, I was checking off American Indian. I mean, I came from India, I'm in America. Then I realized we're still following nomenclature from some guy who got lost in the 14th century. I'm like, come on, guys. So like, it's so absurd, right? And so we're trying to correct social injustice using eigenweights or coefficients in a regression. It's not going to work. Like, we have to engage with the social issues and just not try to have, equal allocation by an algorithm and call it DEI. I mean, that's just absurd.
I will give a little bit of a ray of light here. We also at UC Health partner with our University of Colorado Biobank. So we've integrated our research biobank, of which we have 100,000 patients who've given us either a cheek swab or an extra tube of blood on their routine lab tests to be able to put into the biobank. And we have genetic markers that are, to start with, we're doing pharmacogenomics. So now we can say, you know what, we don't care where you're from, your genes show us that you're not a good metabolizer for Plavix. And at the time of prescribing now, we actually have set up our first 6 alerts of, you're about to prescribe Plavix. Did you know your patient is not going to metabolize? We suggest one of these 2 other drugs. So getting at that in a different way, we are starting to get some traction.
Great. So J. Michael Kramer writes in chat, it's a really nice point that one of the areas where he's found that AI may have some benefit is in areas where it reduces the need for some documentation. So for example, like a lot of the tools that we are using now are replacing kind of hand calculations of things like fall scores and Muse documentation. So is that something that you've encountered at all, or thought about? Is in spaces where we're currently trying to document certain types of risk scores, if those can get auto documented, then maybe it's a little bit of a wash in terms of workflow and kind of burden.
The short answer is yes. The long answer is if you have a couple of days, we can kind of go through. I mean, it's hard, but yes, we're very much trying to automate it. One of our nurses has this out of the box, amazing idea, which is, of course, you'll have to overcome the camera recording, but her husband is a police officer and they have these body cams. If we could get acceptance for in our hospitals having nurses wear body cams, can you imagine the nurse documentation burden is so extreme? I certify that every 2 hours, I turned the patient's body, I changed the dressing, I went in and checked on the patient, have the body cam say, check, went in the room, looked at the patient, had a conversation, that flow seed is checked. Vital signs, I saw you taking the vital signs, I abstracted the number off the machine, that's recorded. So how can we automate all of these as much as possible? We have the vision, and then it's just a matter of overcoming the thousands of pebbles to get there.
So I'm going to close with a last question. And then I think after that, we're going to have a break until 2 p.m. to give folks a chance, regardless of what coast they're on, to take a little break, bio break, get some food, and then move on to the next part. My final question has to do with proprietary models. And I think, Nigam, in your talk, you alluded to the fact that with proprietary models, sometimes if you look at based on the reporting guideline, we don't always have access to complete information about those models. And yet, when we are in, like CT, when you described that, you had different sepsis models to choose from, like, should we build our own? Should we use an off-the-shelf algorithm? This almost always comes up, is that, you've got these apples to oranges comparisons. And so you can't really just pick the thing that has the highest AUC, the best on paper performance. You have to take into account, what's also being told to you and what's absent in the and what's being told to you. So how do you deal with that complexity of not having all the information? And do you feel like if you had all the information, that would be kind of advantageous to you and to like the folks developing models? Like, can we get better in this space? And how do you make decisions in the face of this kind of uncertainty?
Now, this is a very insightful question. I mean, there's a lot of momentum behind having detailed labeling of these models. And we're already at 220. We might end up hitting 300 items to report. And the question I ask is, even if all 300 were reported, and Karandeep, you're in the ICU, new model got installed, and they gave you this package insert with it with all of those 300 items. I mean, is the user in a position to make that judgment? Probably not. And so we need to have a slightly different framework. And there's laboratory testing framework, sort of CLIA regulates that. There's the drug evaluation framework. There's the medical device framework. There's the certification framework for EHR software. And I don't think as a community we've figured out like what's the right template in order to decide whether a model's use is useful. And yeah, so I mean, it's a non-answer, but instead of giving you my thoughts, I mean, let's just acknowledge that we as a community don't have an answer.
Oh, I'll pile on to that one for sure. I mean, even if you did, as Nigam says, put our 300 labels on there, did you label your population, right? So I remember traveling to Louisiana and realizing as I drove through downtown that every other block had a dialysis center. That's a very different patient population than we have in Denver, Colorado. Did you account for that? And, the model's tuned, for example, the Epic Sepsis model is tuned nationally, but does that apply to my population? And how many data elements do you need to certify are the same to say that, yes, I agree, that works? We actually ran the model, and the published sensitivity specificity is very different in our population, but that requires us data scientists on our end to do that. And so I think we're not even to the Model T stage of getting this sort of thing. One model works because we built it for our population. I'm not ready to give this to anyone else other than our population, because who knows what's going on with data sets elsewhere.